Good morning, everyone. Welcome to TeleShadowing. We are live streaming this session on YouTube. Please feel free to ask questions in the chat box as we go along and they will be addressed. I am honored to introduce our mentor for today, Dr. Hayee. Dr. Hayee is a ABPN board-certified psychiatrist working for the Veterans Affairs North Texas Healthcare System. She is a medical director of the Bonham, Virginia Domiciliary Residential Rehabilitation Treatment Program, DRRTP, as well as the Bonham PTSD Inpatient Program. And now it is my honor to request Dr. Hayee to begin today's session. Thank you.
Thank you, Minahil, for the introduction. I really appreciate the opportunity to be here and present this topic of opioid use disorder. I hope everyone is doing well and welcome to the program. So I'm going to start with just a brief introduction about myself, and then we can go to the actual topic. My name is Muniza Hayee. I'm board certified in adult psychiatry. So I started my education from Lahore, Pakistan, and from King Edward Medical College. So I don't know if you're aware of Lahore, but it's in Pakistan, and this King Edward Medical College is one of the prestigious college is in Lahore. I did my medical education from there. From there, I came to America, and I did my residency in general psychiatry from John Peter Smith Hospital in Fort Worth, Texas, and completed the residency in general psychiatry in 2003. After completing my residency from the JPS, you can see the hospital and the logo on the side. After completing my residency, I did a fellowship in addiction psychiatry from the UT Southwestern Medical Center located in Dallas, Texas in year 2004. And again, this nice hospital. It was ranked best in 2022-23. From after the fellowship, I started my first job at the VA North Texas Healthcare System. The VA is the short for the Veterans Affairs, and that was my first job from 2005 to 2008 at the Dallas, Texas. I became the medical director at the VA Texas Outpatient Mental Health Clinic in 2009. And I served as the outpatient mental health director until like 2017 at the Bonham, VA, Texas. The pictures you see in the background are of the Bonham VA. And I don't know if you are familiar with the Bonham or the Texas area. This is to the north and a really beautiful place. As you can see, I just took this picture. This is like a new picture. Actually, I just took a few days ago just to post over here. I mean, it's all surrounded by big lawns and then trees, and the fall is there. And it's really nice and green in the springtime. So it's just like a very nice area and a very beautiful place. Our veterans just love to be here. So, and then, I'm sorry, I just got off track, but I became the medical director at the Bonham DRTP program, which is the Domiciliary Residential Rehabilitation Treatment Program, as well as the PTSD inpatient from 2017 until present. So basically, I've been with the VA North Texas Healthcare System for about 17 years. 12 years I did in the outpatient mental health, and then about like 5 years now in the Bonham domiciliary and the PTSD, which is like an inpatient program. So, I mean, if somebody is interested, I can go in details about, my residency and then this program at the end. But I just want to briefly explain what we do here in the domiciliary. It's like an inpatient, as the name says, the residential rehabilitation program. We have like patients who come here for substance use disorder. We have patients who have PTSD, and we do it's an inpatient, so we take care of like everything. We do the detoxification. We don't do the medical detox from alcohol, opioids, or other substances, but we do the detoxification, and then obviously do the medication-assisted treatments here. It's a long-term residential program. So the veterans or the patients can stay here anywhere from 30 days to about 6 months, and some of them up to like a 1 year. So under one roof, we provide all the care for our patients, including therapies. We have psychiatrists here. We have the family practice, primary care here. We do like all kinds of like therapies, including the CBT and cutting edge, the prolonged exposure therapies for the PTSD, as well as we take care of their mental health. So it's like a residential program which takes care of like patients as a whole. So that's what we do here at the domiciliary. But if someone is interested to know more, I can talk about it in the end when we have time. So this was my introduction, and after this, I'm going to launch on to the topic of the day, which is the opioid use disorder. I have just outlined all these agenda items, which I'm going to go. It looks like a busy slide, but all these topics, I'm going to go briefly, especially talking about the clinical and the medical aspects of the opioid. So basically, I'm going to emphasize on the opioid epidemiology, opioid use epidemiology. I'm going to talk about opioid classes. I'm going to talk about opioid overdose, which is a medical emergency. So that's what I want to emphasize a little more on the opioid overdose treatment. And then overdose, opioid detoxification is the second thing I want to emphasize. And then the medication-assisted treatment, which is the long-term treatment for the opioid use disorder. So these three are the most important topics I'm going to talk in length. And then, of course, the medications which are used in the medication-assisted treatment, the methadone, the buprenorphine, Suboxone, which is the cutting-edge treatment nowadays for the opioid use disorder, and we use a lot. And then in the end, if we have time, I can go over the special situations like opioid use in pregnant females, opioid use in HIV, and opioid acute pain and chronic pain, opioid use. So those are the special situations I have just reserved for the end. If we have some time, we can go over that. So so the epidemiology of opioid use disorder, you see in this slide, you see so many numbers, but what I'm going to highlight is if you see that the people who used opioid in the past year is about 745,000. And then if you look at the top, the 70,000 people, roughly 70 or 80,000 people died from the drug overdose in 2019. And this is like, this is done by the NCHS, and this was the census up till December 2020. So I guess the census covered half of the COVID epidemic because the COVID started in March of 2020. If you see the deaths from the opioid overdose in 19 is 70,000. But then if you look at the number down there, the deaths attributed to overdosing on synthetic opioid other than the methadone in a 12-month period. And this is just the 12-month period ending in June of 20. So this is just the 12-month period. About 48,000 deaths were from the synthetic opioids alone. So out of the 70,000 drug overdoses, 48,000 were from the synthetic opioids. And then if you look at the right, it's 14,000 people roughly attributed to overdosing on the heroin. So these figures say a lot about the opioid use disorder. The next is about the opioid use overdose deaths in the year 2020 by age. So if you look at this graph, you see like from the age of like 25 to roughly, I would say 50 years, there's like a big jump in the overall overdose deaths in the US in 2020. Almost about 50% people died from opioid overdose in this age group. The rest of the ages you can see, but that's the highlight of this graph I'm going to talk about. Between the ages of this 25 to 50, you see like a 50% of the deaths. And then this graph actually is the total overdose deaths among all ages. But I want to emphasize that if you look at the total deaths are about 91,000, or you can say 9179. The male deaths, which is like a yellow line, if you see, it's about 70,000 from drug overdose. This is just the drug overdose from any, the next I have one more, but this is like the drug overdose. It can be from any drug. 70,000 males and about roughly like 20,000 female. And this is, again, if you look at the year, I want to emphasize like 2018, 19, and 20. There's like a spike going on. If you see more in the males and also in the females, and again, this just shows until the June of 2020. I don't have the last 2 years, 20 and 21, and we are in 22. So, but this is just the start of the epidemic. When we had this, even before that, you see a surge in the male and the female in 19 and 20. So the next slide is actually the opioid. The previous one was overdose from any drug, but this is like overdose deaths involving any kind of opioid. And again, you see that a male, which is like a light yellow, if you follow, you see like there's about almost like 47,000 deaths. That the same number which I showed in the first slide, it shows that there's like a peak going up from 18, 19, and 2020. Like a female and male is yellow, and then the orange is a female line. You see, it's like it was steady, and then from 15 until 20, you see like this going up towards up. So now now this is a slide showing national overdose deaths involving the prescription opioids. The previous one was just the opioids, but this one I want to show from the prescription opioids. And the prescription opioids, as you know, include like all the pain medications, methadone, buprenorphine, all the prescription opioids. And again, what I'm going to emphasize here, if you see, again, if you follow the lines, the yellow, the dark yellow is from the prescription opioids, and which includes the synthetic opioids, other than the methadone. And again, you see it was like steady, but then from roughly from 2015 until 2020, if you follow this yellow curve or line, it has gone up to almost like 10,000. Is just involving the opioids which are the synthetic opioids. And I'm going to talk about the synthetic opioids in the next few slides. And then the clear line is the opioids without any other opioid. So that has actually gone a little down. But then the mixing of the prescription opioids with the synthetic, if you see, it has a surge like going up. And then the clear line or the light blue line has gradually like come down. It's still high, but it's come down. But the mixing of the prescription opioids with the synthetic ones has gone up. I just wanted to show this. This is like a significant thing, like the rise in the use of synthetic opioids, especially the fentanyl. I'll talk about this fentanyl a little more in the next couple of slides. So this was all about the epidemiology. Now, the definition of opioid use disorder. The opioid use disorder, which is defined in this DSM-5 as a problematic pattern of opioid use leading to clinically significant impairment or distress. I want to emphasize one thing over here, is that the terms, the opioid use and the opioid dependence, which we used to use in DSM-4, I don't know if you're familiar with the DSM-4 or the DSM-5, but these are the standard criteria to use for the opioid abuse and the opioid dependence in the DSM-5. Both are the obsolete terms now. And we now use DSM-5 in psychiatry to diagnose the psychiatric problems. And the DSM-5 does not use the terms opioid use and opioid dependence. Both are obsolete now. But I still see many people are using the terms, but that's why I want to emphasize that we just use the term opioid use disorder, not the opioid abuse or dependence. So I have put the next two slides just to show why we don't use the substance abuse or the substance dependence anymore, and we just use the substance use disorder, and then we grade the substance use disorder as mild, severe, mild, moderate to severe. So substance use disorder is a clinically significant impairment distress as manifested by one or more occurring in the 12-month period. So this was like an old diagnostic criteria that we needed only one out of the four, one or more in the 12-month period. And this was about recurrent substance use resulting in failure to fulfill major obligations at work, school, or home. For example, repeated absence or poor work performance related to substance use, substance-related absences, suspensions, expulsions from school, neglect of children and household, recurrent substance use in situations in which it is physically hazardous, for example, driving, automobile, operating machinery, and recurrent substance-related legal problems, and then the continued substance use despite having persistent recurrent social or interpersonal problems. This was the criteria of substance abuse in the DSM-4 that we used to use, and we only needed one or more in the 12-month period. Then substance dependence, I just wanted to show these two so that you can have like a clear idea why we are using the substance DSM-5 and the criteria for the substance use in the new DSM-5. So substance dependence was also defined as leading a clinically significant impairment or distress manifested by 3 or more or out of the 6 fall in a 12-month period. And the dependence is, we included tolerance, which is defined by need for markedly increased amounts of substance to achieve intoxication or desired effects, or markedly diminished effect with continued use of the same amount of the substance, meaning that the person has to use, number one, more and more amount of the substance to obtain the same effect from the drug, or a person is no longer having the same effect that he used to have. For example, a person was using, I'm just saying, for example, like 10 milligrams of heroin, 10 grams. So over a period of time, a person who's going to develop tolerance will not only need more and more, for example, may need 20, may need 30, 40 to obtain the same euphoria, to obtain the same effect, high effect from the heroin. So that's tolerance. And then the person will have diminished effect. For example, the 10 milligram will not give him the same high. The 20 milligram will not give the same high. So the person will continue to use or increase more and more. And then the withdrawal, which is actually, we say like a physical dependence, is characterized by if the person stops the substance or it cuts down, the patient will have some withdrawal symptoms, which is specific to the drug or a substance the patient or a person was using. Number 3 criteria was the substance is often taken in larger amounts over a longer period of time, and there's a persistent desire or unsuccessful attempts to cut down. A great deal of time is spent in activities in order to obtain the substance, and important social and occupational recreational activities are cut down. So out of the 6, we needed 3 for the substance dependence. So the problem with abuse and dependence in DSM-4 was, number 1, does not reflect the severity. The both did not comment on the severity. And it was found or felt that the legal consequences are not well correlated with severity of the substance use. And the abuse does not necessarily lead to dependence. Both have variable courses, because many patients with abuse may have problems with those, more problems than those with dependence. So that's why those were the reasons we no longer use those terms. So in the new DSM-5, I want you to understand that craving has been added as a criterion, and we'll see that in a second when I open the next slide. And we only need 2 criteria for substance use disorder. So to diagnose a substance use disorder, we only need 2 criteria. And the substance use in the new DSM-5, the substance use disorder is graded as mild, which 2 to 3 symptoms, moderate 4 to 5 symptoms, and severe is 6 to 11. So, and neither DSM-4 or 5 talk about the quantity and the frequency criteria. So we only need two criteria for the substance to diagnose the substance use, and the craving criteria was added, and the legal consequences criteria was taken out. So now if you look at this, I have combined this here, the substance use disorder, or we're talking about the opioid use disorder. So in specific, there now the abuse and dependence criteria have been combined. If you carefully look at this slide, I mean, I've already gone through each and every criteria. The DSM-5 actually combines both the criteria that we used to use for the abuse and dependence in under one, like all the criteria are there, but the craving or strong desire to use opioids has been added in the DSM-5. So basically, the legal criteria has been taken out, and the craving or a strong desire to use the substance. As today we are talking about the opioid, so I'm using the term, and I've put the term for opioid over here, but you can use it for alcohol use disorder, cocaine use disorder, cannabis use disorder, amphetamine use disorder. But today, since we're talking about the opioids, I'm using the term opioid. So it's opioid use disorder criteria. So basically, it's all these criteria makes up the opioid use disorder. And then you say, so then you need only 0 to 1 symptom is like no diagnosis. So if only one symptom is present, there's no diagnosis. Mild is 2 to 3. For example, somebody who has, for example, cravings and now has developed like tolerance, that will be counted as mild opioid use disorder. Moderate is 4 to 5. Like, if the person has, like, let's suppose that opioids are taken in larger and larger amounts, a great deal of time is spent, craving is there, recurrent opioid use resulting in fulfilling major obligations. If the person has tolerance and or withdrawal, actually 4 to 5 symptoms, that will be, and then we will say opioid use disorder severe. That's how we diagnose, and that's how we grade them, like opioid use disorder. And we say a subspecifier mild if a person has 2 to 3 symptoms, opioid use disorder moderate if a person has 4 to 5, and opioid use disorder severe if a person has 6 or more symptoms out of all this. So now I have a small case here just to kind of like emphasize what we talked. 59 years old male present to the mental health outpatient clinic, reports that he's been taking hydrocodone for his knee after his knee surgery for 3 months. He was arrested 3 weeks ago and got DWI and after he has an accident while driving intoxicated. He's reporting recurrent use of hydrocodone while operating a vehicle. Now he's reporting desire to increase the usage. So does he have an opioid use disorder? Number one question. And what is the severity? And that's how we define an opioid use disorder in DSM-5. First of all, if the question is if the person has a substance use disorder. So if you look, yes, the person has an opioid use disorder because he's reporting recurrent use of the hydrocodone while operating a vehicle. Number 2, he's reporting a desire to increase the usage. That makes about 2 criteria. And if you notice, I'm not including this legal issue, a DWI, in this because it's the legal criteria is no longer included as one of the criteria to diagnose a disorder. So yes, the person has a substance use disorder, but I would say the severity of this is about mild. This is how, and then if you keep on adding symptoms, so it will be substance opioid use disorder. And since we are talking about the opioids, I'm saying it's an opioid use disorder. And if the severity, if the person has more than 4 symptoms, it's moderate. If 6, then severe. So now the pharmacology of the opioids. For the sake of time, I'm emphasizing more on the stuff which is clinically important, but few slides I have to talk about just to make my point clear as we go along. But the pharmacology of opioids is that is the first pass after oral ingestion, and morphine only 50% is orally absorbed, but methadone is 80 to 90%. Analgesia is about duration 6 to 6 hours, but depression and constipation may last longer. They are metabolized by the liver. At this point, I want to emphasize that opioids are metabolized by the cytochrome P450, and we need to know about the 2D6 and 3A4 interactions, and I have listed in my other slide. So they are excreted in the urine and the bile. So anyone who has impaired hepatic and renal functions can increase the concentration and amounts of the opioids. Now, the opioid types. So as you know, like people use like opiates and the opioids, the terms are used interchangeably. So basically the opiate, the term is natural substances which are derived from the opium. The natural opiates are the morphine, codeine, and the thebaine, and the semi-synthetic opioids. So I want you to see the semi-synthetic opioids and the synthetic, because remember the slides I showed in epidemiology, they show the rise in the use of the synthetic and the semi-synthetic opioids and the overdoses and the deaths from combining the prescription opioids with the synthetic opioids. That's why I wanted to show those in epidemiology. And here, the semi-synthetic opioids, they are the modifications of a naturally occurring opioids which come from the natural opioids. These are the heroin from the morphine, hydromorphone from the morphine, oxymorphone from the morphine, buprenorphine and oxycodone from thebaine, and hydrocodone from the codeine. The synthetic opioids, which are fully synthetic opioids, which are just manufactured, and they are fentanyl, methadone, meperidine, and the tramadol. So the half-life of the opioids, I just wanted to show, just to make a point that why the deaths are rising in synthetic opioids, especially the fentanyl, because fentanyl is a that is 70 to 125 times potent from the morphine. It's 75 times potent than the morphine and has a very rapid IV onset of action in 1 to 2 minutes and relatively short duration of action in 20 to 30 minutes. So that's why it has a rapid onset of action, 1 to 2 minutes. So the overdose is very sudden, and it happens in 20 to 30 minutes if someone is mixing the fentanyl with other opioid medications, prescriptions, or even heroin, morphine, other kinds of opioids. I have seen like fentanyl is being like mixed with other drugs like cocaine and methamphetamines, and sometimes the patients who buy cocaine and methamphetamines really don't know that the fentanyl was there, or the cocaine was laced with fentanyl, and that's how they accidentally overdose on the fentanyl because of mixing of fentanyl with other drugs. So this is like the half-life showing just a comparison here that again fentanyl has a very short half-life. If you see at the hydrocodone has also a short half-life, and then the oxycodone. The longer half-life is basically, as you know, is the frame where the time where the medication is reduced into half. So obviously the opioids which have a longer half-life, will stay in the body longer as compared to some as compared to the opioids, which have like short half-life. They will stay shorter, but then the onset of action will be faster, just like I said about the fentanyl. So if you look at the potency again, fentanyl is at the top. And then if you look down towards the weaker, we have the tramadol and the codeine, and the methadone is in the middle. So the next slide is the timeline. I just talked about the short-acting opioids are the heroin, oxycodone, hydrocodone, and onset of action begins in the 6 to 12 hours after the last dose and peaks at 36 to 70 hours and last about 5 hours. That's why I showed the half-life, because it's important to know about the onset of action and the duration of the withdrawal symptom. And then this is the intermediate opioids, the OxyContin, about 17 to 24 hours, and the long-acting opioids is methadone, 36 to 72 hours, almost about 3 days, and takes longer before it peaks. So look at the comparison. The methadone will take about 3 days, and then it will stay longer in the system. This means that the withdrawal symptoms for methadone will appear later as compared to somebody who's using short-acting like fentanyl, heroin, oxycodone, and hydrocodone, which will have the symptoms in the 6 to 12 hours, and then they will peak sooner as compared to methadone or other long-acting. The symptoms will appear later and the withdrawal symptoms will last longer. But the medications which have long half-life generally have less severe spontaneous withdrawal symptoms, but longer withdrawal symptoms. This is the significance. So again, this is another slide showing the duration of analgesia, and the same thing which I was saying. So this is like a short case. A 30-year-old female presents to the ER requesting substance use rehab, left the ER, and then was brought back by the police after 30 minutes, reporting that she was found shooting IV meth in the parking lot. Suddenly, she had a decreased respiration, heart rate, and was not responding. Reports that she's been using IV meth for the last 12 months. She has been buying IV meth from a new drug dealer. And this case, the cases which I'm putting, these are actually the real cases which I have seen. And I just put these cases here to explain the topic. So looking at this, which I said earlier, that there is like a lot of mixing of these opioids with other drugs, and that's why there's a rise in the accidental or incidental overdoses from opioids, which may be from prescription opioids or like the street opioids. So this lady is a regular IV meth user. But the key word I want to emphasize is that she has been going to a new drug dealer, and she never knew that there was like a fentanyl mix with the IV meth. So the typical, if you see this like a overdose or the intoxication, is not from the meth. These are not the typical symptoms, but this is somebody who is like intoxicated or overdosed on the heroin, or it's like, since it is so short, it's a fentanyl. So this is like a real case which happened, and we found out later after we tested the urine drug screen came back, she was found positive for the fentanyl. So because of the rapid onset of action that she was in the ER, she left, and right after few minutes, 30 minutes, she was seen and again in the ER with the symptoms of overdose or the intoxication. So the opioid receptors, there are three types of opioid receptors, mu, kappa, and delta. And the mu receptors, they're found in the spinal cord, in the presynaptic sites. So addictive effects of the opioid are through the mu receptors. So that's what you should know, that the effects of the opioid is through the mu receptors, and then the role of the delta and the kappa is not well understood. So drugs that activate the mu receptors. I'm sorry, the next three pictures are not so great. These are the actual pictures I just took, from my cell phone, and just wanted to show over here, just to show the drugs which activate the mu receptors. These are the morphine, the methadone, the hydromorphine, fentanyl, codeine, heroin, levo alpha acetyl methadol. This we no longer use because of the cardiac arrhythmias and the prolongation of the QTC, buprenorphine, oxycodone, and the hydrocodone. So these are all different kinds of opioids which act on the mu receptors. So now I want to introduce the concept of the full and the partial opioid agonists. The full opioid agonists are the heroin, methadone, oxycodone, and the others. By that I mean they activate the mu receptor and they fully occupy the mu receptors. They are highly reinforcing and is the most abused opioid type because it occupies the opioid fully. The partial agonists, they activate at the lower level. They are less reinforcing and they are less abused opioid type. This next picture, and again, I'm sorry, this is not the best picture. I took it from my cell phone just to show that the concept here. So the top line is a full agonist, and as you see, and then the middle line is of the partial agonist. So even both the doses are about the same, like roughly near the same. But if you look at the partial agonist will occupy the mu receptors partially, but then there is like a plateau in the case of the buprenorphine we'll talk about later. And then this is like a full agonist which has occupied the mu receptors like 100%. And then the antagonist it doesn't occupy the mu receptors. So the neurobiology of the neuroreceptors, they are widely distributed. In the thalamus, they are responsible for the analgesia, in the cortex for the impaired thinking. The prefrontal cortex is for the individual thinking. But the ventral tegmental area, the VTA, and the nucleus accumbens, the NA, is associated with euphoria and experience of high, and the brainstem for the respiratory depression. So this is the neurobiology. The opioid intoxication. So the next few slides are about the opioid intoxication, which is like a medical emergency on the opioid. So it's an overdose, and the overdose looks like face is extremely pale and clammy. The body goes limp. The patient starts vomiting. The symptoms of pinpoint pupil, decreased heart rate, blood pressure, unresponsiveness, unconsciousness. Respiratory depression is the cause of death. Snoring, cold and clammy, discolored lips. So that's the emergency, because the opioid, they can depress the respiratory drive and they cause death. Treatment of an overdose, as I said, is a medical emergency. So naloxone is a medication which is like an opioid antagonist. It's the FDA-approved medication to reverse opioid dose rapidly. It is an opioid antagonist, meaning it binds to the opioid receptors and it can reverse and blocks the effects of other opioids such as heroin, morphine, and oxycodone. Administered when the patient is showing signs of an overdose, naloxone is a temporary treatment and its end effects do not last long. Therefore, it is critical to obtain medical intervention as soon as possible after administering. And naloxone can be given by intranasal spray, and it can be given with a subcutaneous injection. Next case, 50 years old male was seen by the pedestrian lying on the sidewalk. Pedestrian noticed track marks on the patient arm, and there was a syringe in the vicinity. The patient also had his medications on his person. This means that patient had the medications with him, symptoms of pinpoint pupil, decreased aspiration, and blue lips. So besides calling 911, what else can be done by the pedestrian? So I want to emphasize the point that now the person who has an opioid use disorder, this is like when they are given like a naloxone, intranasal naloxone that they keep with them, so that in case of like any overdose, the naloxone can be administered right away because it's a life-saving medicine. So usually, like, but again, the naloxone, the person who's like overdosed and who's like unconscious obviously cannot administer the naloxone to himself or herself. But if somebody is a known opioid user, and you know that it's a possibility that a person is overdosed on overdose and showing signs of decreased aspiration, the rescue medicine is the naloxone, and that's the pedestrian. And the giver here is the patient also had his medications on his purse. I just put this line for a purpose because, I mean, to look for naloxone kit in these medications will be the lifesaver for this person. So how does this work? For the sake of time, I think I'm going to go quickly over this. I just wanted to show this picture as just to show this is how the nasal spray looks like. And anyone who uses opioids can experience an overdose at any time. When a person survives an opioid overdose, it is because someone knew what was happening and how to take action, which is to give this naloxone can block the effects of the opioids. So this is the nasal spray. This is how it looks like. At the dorm or at the VA, every person who has an opioid use disorder is given this nasal spray, and they keep with them, and they are required to tell their family that they have this nasal spray in case an overdose happens. This is like a lifesaver, and this has 4 milligrams. And then the most common effects of Narcan includes dryness, swelling, muscle and joint pain, and headache. So these are the steps for an opioid overdose. Like first of all, you try to wake the person, then call 911, and you give naloxone spray. And the one thing I want to emphasize is that do not prime or test the nasal spray. In other words, do not test with the nasal spray, but then insert the tip of the nozzle into one nostril and press the plunger. So this is how you give one dose in one nostril. And and in the meantime, you call 911, and then you have to do the rescue breathing. These are just the steps of the CPR that you have to do in the meantime. And number 4 step, consider naloxone again if there's no response, and then you have to put the patient in a recovery position so that they don't vomit. So the key point here is that methadone patients can overdose for 24 to 48 hours, and they may have to be given a naloxone again just because methadone is long acting. And just the point I was making that now the intranasal naloxone is a major public health initiative with intranasal naloxone to be given to every patient who has an opioid use disorder. So the opioid withdrawal symptoms, early symptoms in the first 24 hours are muscle aches, restlessness, anxiety, lacrimation, runny nose, sweating, inabilities to sleep, yawning. And then the opioid later symptoms of withdrawal are diarrhea, abdominal pain, goosebumps, nausea, vomiting, dilated pupil, rapid heart rate, and blood pressure. So we covered the overdose or the intoxication. Now we are the second important part of the opioid is the opioid withdrawal. Although opioid withdrawal is very unpleasant and painful, but it is not life-threatening. In other words, the patient will not die from an opioid withdrawal, but it's nasty, it's unpleasant. Case, a 25 years old male presents to the clinic with opioid use disorder. He used an opioid 3 days ago. After 3 normal days, he came back reporting muscle pains, diarrhea, insomnia, and sweating. Again, this was a true case. What class of opioid was used by the patient? So if you remember from my previous slides, which that's why I put them there, about the half-life, the peak of the symptoms, and the short and long-acting opioids, the patient used methadone just because, look at the time frame, he used the peak of the withdrawal symptoms with the long-acting opioid is about like 48 to 72 hours, and that's how he reported the symptoms. The symptoms from methadone or any long-acting will come later, will last longer, and will need more treatment. This is like an opioid withdrawal timeline for the start after the last dose, 72 hours the peak, 1 week is the physical symptoms, 2 week just the depression, anxiety, restlessness, and then in 1 month they have the cravings and the depression will go down. This is the timeline. The neurobiology of withdrawals. Increase in heart rate, increase in blood pressure, respiration and sweating and diarrhea is due to the hyperactivity at the locus ceruleus. And that's why the clonidine and opiates can reverse these effects. The clonidine, because it's an alpha-adrenergic agonist, which works on these symptoms. And then the increased GABA effects and the reduced dopamine in the nucleus accumbens will cause the dysphoria, depression, and the cravings in withdrawal. And that's why the opioids like methadone and buprenorphine, Suboxone, reverse these effects in withdrawals. So briefly, the scale which we use to measure for the opioid withdrawal is the COWS, which is the short for the clinical opioid withdrawal. This is the clinical opioid withdrawal scale that we use in clinical practice. The other scale, the objective opioid withdrawal scale, is hardly used, but I just named it. So this is the COWS scale. I just want you to scan through it. It's a busy slide, but these are some of the criteria that we use. The totals, if the person scores 5 to 12, it's mild, 24 is moderate, 36 is severe, and more than 36 is the severe withdrawal. So this is the COWS. This is the withdrawal scale that we use, COWS. It is used by the nurses, and that's how we monitor the withdrawals. I just want to emphasize the withdrawal symptoms in babies which are born to addicted patients. So this is something I just want to put and share, that the patients who have used opioids in the pregnancy, they particularly the methadone or any kind of opioids, even the buprenorphine, can have the babies are born with a withdrawal symptom, which is called the neonatal abstinence syndrome. And this is like, I highlighted this area, that one baby diagnosed with neonatal abstinence syndrome every 19 minutes in the United States, who are for the pregnant females who are using the opioids. And the abstinence syndrome symptoms in babies, you can, if the baby has these symptoms of poor feeding, vomiting, and even seizures, you can suspect that the patient was using or abusing opioids in the pregnancy. So detoxification from opioids is from the inpatient methadone, inpatient Suboxone, and non-opioid clonidine. So think of the detoxification treatment for opioids as somebody that you will use, you would use medications to help them with the symptoms of the withdrawals, and basically just like we use for alcohol or with benzodiazepines, we use we use the detoxification treatments for opioids. So the urine toxicology, we use like a gold star for urine toxicology, and you have to order the opioid, because the regular urine screen will not test for the opioids, but the gold will test for the codeine, hydrocodone, and the methadone. And fentanyl you have to order as a separate screen. So inpatient methadone detoxification. The next couple of slides I'm going to go fast because this is something we used to help with the withdrawal symptoms. So initiate treatment after a documented withdrawal. Start methadone with 20 milligrams, and then you can repeat it in 2 hours. And the inpatient really requires over 40 milligrams. And then remember, the detoxification is you are using to help a person with the withdrawal symptoms from methadone, from opioid. So you just help them with the symptoms, and then the detoxification you have to taper it down to, so you cut by 10 milligram every day down to 20, and then after that it's 5 milligram to 0. For example, if you have to go up to the methadone up to like 80 milligram, you have to cut it back. After the detoxification is completed, you cut down 10 milligrams down to 20, and then 5 milligrams every day after that, once you're down to 20, and then down to 0. So this is the other method, inpatient Suboxone or the buprenorphine. You start with 4 milligrams, and then you can use up to 8 milligrams. Day 2 is 8 to 12, day 3 is 6, and the 7-day protocol may be more effective. And the non-opioid detoxification is from clonidine, which is an alpha-2 adrenergic agonist, which can help with the withdrawal symptoms, but it will have no effect on the cravings as compared to methadone and the Suboxone. So now I'm to the last topic, which is the medication-assisted treatment. And what is the medication-assisted treatment? This is like the long-term treatment for the opioid use disorder, which is we use in the outpatient clinics for somebody who has been using opioids, and now they want medication-assisted treatment for the long term. And the purpose is to prevention of the withdrawal and induction of tolerance. And medication-assisted treatment we can use for 18 years and above for methadone, and for 16 years for buprenorphine. And it is recommended for medically compromised patients who are using opioids, street opioids, HIV, and pregnant women especially. Treatment options, again, methadone, and this LAM, which is the alpha acetylmethadol, was taken off the market after the black box warning about the arrhythmias. And the buprenorphine is a partial agonist, and I'll talk about buprenorphine in a little bit more detail at the end. And what is the purpose of this medication-assisted treatment? This is to stabilize lifestyle, improve health and nutrition status, decrease in criminal behavior, increase employment, decrease in homelessness, decrease in injection drug use and shared needles. So this is why the patients are put on a long-term methadone or the Suboxone, buprenorphine. So methadone induction, one thing I want to emphasize here, that you have to take a good history that they are using, they were using opioids. EKG, if you are using methadone, you in a long-term medication-assisted treatment, you have to make sure and you do the ECG, because methadone can cause the QTC prolongation. Methadone induction, the key is to start slow and low and go slow. And the federal regulations are the first dose should not be more than 40 milligrams on the first day. And then if there's no evidence of opioid withdrawal, you can increase it. And then you can increase the dose every 5 to 7 days. And the target dose for the methadone medication-assisted treatment is 80 to 100 milligrams. And when once you have reached the target dose, the patient should not have cravings or the withdrawals. The patient should not have the euphoria. And that's the target dose for that patient. But the usual target dose is about 80 to 100 milligrams. So the side effects, the constipation is very common. And this QTC prolongation, I want to emphasize here, decreased libido or weight, increased appetite and weight gain. So drug interactions are important in the sense because these are the medications here which can decrease the methadone concentration by inducing this cytochrome P450. In this slide, and this drugs, remember the HIV medications which are commonly used in HIV patients, they can decrease the methadone concentration and they can cause the opioid withdrawal symptoms. Then the medications which can increase the methadone concentration can cause side effects, particularly the QTC prolongation. I want to emphasize the 2D6 inhibitors, especially the 2D6 antidepressant, the Prozac, the sertraline, or the Paxil, which we use, and they can cause the side effects. So the Suboxone or the buprenorphine is actually the cutting edge now for the long-term or the medication-assisted treatment for opioid use disorder. And it's a combination of two medications. It's a buprenorphine and then naloxone, and it's a partial mu agonist and the antagonist. Both are in one medication, meaning that it's a partial mu agonist. It only partially activates the opioid receptors, but it has a strong affinity for the mu receptors, slow to dissociate, and blocks other opioids from binding. So that's why the Suboxone will make you feel better, and there's less cravings, less withdrawal symptoms because of this nature of it's a partial mu agonist. As compared to the full mu agonist, it's a partial, and that's why it actually has a ceiling effect, and it helps with the euphoria and controls the cravings of the medications. And this is the picture for the comparison of the full opioid, which is the heroin or the methadone or the hydrocodone, and this is the partial agonist, which is the buprenorphine. It only partially occupies the receptors. These are the different FDA-approved buprenorphine medications. This is the sublingual, the Subutex, Suboxone sublingual films, the Sublocade, but the one which we normally use is the sublingual Suboxone films, or the tablet, the Suboxone naloxone combination. The Suboxone comes in like 2 milligrams, 4, 8, and 12 milligram dosages, and you place the film under the tongue. This is which is the if you are using the buprenorphine film, and it comes in these dosages of 2, 4, and 12, and generally takes 20 to 40 minutes. So just I want to spend just few more minutes on the facts about the Suboxone, why it has become a lifesaver medication. It's widely used for the following facts. Number one, that it can be prescribed from the office-based practices by physicians who have received a waiver because it only requires 8 hours of training. And office-based training, office-based prescription can be used for about 30 days. It's an advantage over the methadone because for the methadone, the patient has to go to the special clinics to obtain methadone. And they have to go 2-3 times a week, but buprenorphine, you can give a 30-day prescription. Obtaining primary mental health and opioid dependence treatment from one physician improves the compliance. Suboxone can also make a person sleepy, dizziness, slowed breathing, but these side effects may be longer first, but again, they are very temporary, and the person once gets used to this does not have side effects. If a person tries to inject Suboxone, I want to emphasize that why the naloxone is added to the Suboxone. Like naloxone is an antagonist, why it's added. So when the person takes the Suboxone orally by sublingual or a tablet form, the naloxone does not have any effect because naloxone is poorly absorbed when taken orally from the digestive system. However, if a person actually crushes the tablet or tries to inject it, then the naloxone part becomes active, and then it binds to the opioid receptors, and then it will immediately cause the withdrawal symptoms because it's an antagonist. Because it will replace the buprenorphine part, and it will put the person in a withdrawal, and that's why it's a deterrent for the misuse of the medication, and that is one of the reasons it has a greater safety profile and a lower abuse potential. And this is the ceiling effect. I talked about this already. So the ceiling effect of the Suboxone will produce a certain degree of euphoria and pain relief, but that effect will be maximized at a moderate dose, and it will not continue to increase at a higher and higher dose because this is the very special phenomenon of the Suboxone or the buprenorphine. This is the ceiling effect. So in other words, this minimizes the utility of taking more and more of the medication and just avoid any overdose on the medication. And this is because of the ceiling effect. It is nearly impossible to overdose on Suboxone, making buprenorphine less dangerous than the other opioids. Just imagine that even if you take more and more, because of the ceiling effect, because the Suboxone occupies the mu receptors at a very moderate dose, the person will not feel high. Even if they try to overdose on the Suboxone, they will not feel high as compared to a full agonist, and that's like a very important property of the buprenorphine. So the key thing about starting the Suboxone is that you have to make sure that the person, you start the short, after the short acting 12 to 24 hours, you start Suboxone after the person is free from the short acting for 12 to 24 hours. And 24 hours for the sustained release, and 48 to 72 hours for the methadone. So the time to start the first dose of the Suboxone, which is the 2 to 4 milligram, is the cow score of 10. That's how you decide where to start. When there's a score of about 8 to 10, this means that the patient is in mild to moderate withdrawal. That's when you start the Suboxone when the person is in mild to moderate withdrawal. Side effects from Suboxone, they are listed here: constipation, dizziness, dry mouth, tooth decay, muscle aches, fever, tremors, palpitations. Some serious side effects, respiratory depression can happen, but it's, as I said, the risk of that is very low because of the ceiling effect of the buprenorphine. These are the drug interactions with buprenorphine. Again, HIV medications you have to keep in mind will increase the buprenorphine concentration, and the rifampin, which is the TB medication, will decrease the buprenorphine. Naltrexone, which is an opioid antagonist, can also be used for the medication-assisted treatment. But again, remember, it's an opioid antagonist. You have to start 7 days after the short-acting opioids and 14 days after the long dose of the opioids. And the dose is usually 50 to 100 milligrams. And naltrexone can be used in patients who are really motivated to use, because naltrexone will trigger the withdrawal in any person with opioid user. And this is the special population slide I just wanted to put in the end. I already talked about the pregnancy and the neonatal period. Remember, both methadone and buprenorphine can be used during pregnancy, but neonatal abstinence syndrome happen in both. But it is less severe with buprenorphine, and both are excreted in the breast milk. So remember that pregnant females who are using opioids, we can use both methadone and this buprenorphine, and both are excreted in breast milk. And then HIV with opioid use, remember the drug-drug interactions are very important to remember. Then opioid dependency and acute pain. Remember that you have to give the regular dose of the methadone plus short-acting pain for the severe pain. With buprenorphine blocks most mu receptors, and therefore may be a challenge to give analgesia. So you have to use short-acting when you are using. When you have to use when the person has acute pain, for example, they go for dental extractions or they have the surgery, and they are all on methadone or the Suboxone or the buprenorphine, and they have to use medications for acute pain control. Then you have to either use short-acting, or you can stop the buprenorphine when they have to use the analgesia for acute pain. And then opioid dependence and chronic pain. Again, don't recommend limited evidence of long-term opioids for non-malignant pain. But if you have to use, then chronic pain, and they may do better with methadone. And again, the role of counseling, we use CBT, which is the cognitive behavioral therapy. Motivational enhancement therapy can be used, and the other behavioral therapies in 12 steps. And that brings me to my last slide. Thank you so much.
I'm Robin. I'm a PhD student at Johns Hopkins. I also work with TeleShadowing, so I'll handle our Q&A. Do you have some time to take some questions?
Hey, Robin.
So our first question is about some of this medication-assisted treatment. Is it just safety profile that leads to the difference in how buprenorphine and methadone are handled? And I think you touched on it a little bit, but what are some of the differences in patient population that are given methadone and monitored versus people that are just prescribed Suboxone?
So the first thing is that methadone, as you know, is only dispensed by highly specialized places. For example, at our facility, we are not equipped to use methadone. We only use buprenorphine. So that's one, because methadone dispensing has to be done out of the specialized clinics. It requires more staffing. In terms of like the safety of the methadone overdose, as you know, methadone is a full mu agonist. So the risk of like overdose on the methadone is high. The risk of the side effects, for example, the heart, the QTC prolongation, that is high. If the person overdoses, then obviously, it's like more dangerous. The withdrawals from methadone, since it's longer acting, the withdrawals are also like more prolonged, more severe. Now, buprenorphine is safer because, of the facts which I mentioned already, that it's number one, it can be prescribed by even by a primary care physician who's done like who's done like an 8-hour training. It can be safely be dispensed by them. It improves compliance of the patient, because you can dispense like a 2-week prescription to them, or a 30-day prescription to them. And that helps the patient because they don't have to come to the clinic so frequently. The safety profile is like, if a person, for example, buprenorphine is a partial mu agonist. This means that buprenorphine binds to the mu receptors. It has a greater high affinity for the mu receptors. So now if a person who's using opioids and now overdoses on opioids, prescription opioids, street opioids, heroin and morphine, that person is a very low risk for an overdose, because the buprenorphine has a greater affinity for the mu receptors, and so the patient is not at risk for having like an overdose. So that's one thing. Number 3 is the sealing effect of the mu receptors, because the as Suboxone will occupy the receptors. Then it doesn't matter if the person is using other opioids or street opioids or outside, the person will not have a high or euphoria because of the sealing effect of the Suboxone, because the Suboxone has already occupied the mu receptors. That's a safety on the Suboxone from the overdose, from the mixing of the opioid of the other opioids.
So how do you think we can increase the effectiveness of these methadone clinics, like as far as compliance, and maybe even at earlier stages with like needle exchange programs where they're trying to reach out to people? How do you think you can increase the effectiveness of that?
I think we can increase by number one, actually by more like education, and by more staff, by training staff. We can improve methadone clinics, but that's I think the number one thing, that it is dispensed by the highly specialized clinics. But again, you have to keep the safety aspect in mind, because again, no matter if we open clinics, we cannot dispense like a week or a 2-week or a 30-day prescription to the patient on methadone. As compared to the patient who's on Suboxone, we are comfortable in giving them 2-week. I mean, when I start a person on Suboxone, I give them initially like a 7-day prescription or a 2-week prescription. I won't do that with methadone because of the less safety profile, the risk of like overdosing on it, and then the risk of like, mixing of other opioids can cause like, accidental overdose. So those are the things, no matter if you open clinics, the safety aspect you still have to keep in mind.
I thought it was interesting when I learned they were mixing the methadone with a component that would make your like urine green, so they could know if you were actually taking it or not. So obviously opioids have gained popularity and led to this sort of epidemic level because they're so effective at reducing pain. What is the mechanism through which like agonism at these opioid receptors leads to such strong pain relief? And why is this particularly high risk for addiction?
So I'm sorry, your voice was cut off in the middle.
Oh, sorry. So I was just asking why agonism at opioid receptors leads to pain relief, and then why is this particularly addictive?
So as you know, the mu receptors are like, present throughout the central nervous system, in the thalamus and in the brainstem, like in the peripheral nervous system. So that's how, these opioid, they go and attach to these mu receptors, and that's why they cause like analgesic effect from binding to these receptors. So then that's how, because the patient can develop like tolerance and then dependence on using the pain medications, especially like the short acting, that's what leads to like an overdose or like, dependence on these medications, because the person develops tolerance easily on the short acting ones. And that's one thing, that's why they keep on using more and more in order to develop or have the same analgesic effect, although they are full, maybe full opioid agonists, and they occupy the mu receptors, but just because they develop tolerance, they keep on using more and more and more to attain the same analgesic effect. And that's why the dose that they were prescribed originally will no longer work,
So once you've already reached the level of addiction and then you're going through withdrawal, in previous sessions, we've talked about how alcohol withdrawal, if not handled correctly, can be fatal. Why is it that opioid withdrawal is not?
So the opioid withdrawals, I mean, it's like the same way as the other intoxications are, but just because some of the opioids, they are the partial opioid and the full agonist, the withdrawal symptoms. And the less severe with some and more severe with less, but other opioids and the areas, they actually in the brain that helps with the withdrawal symptoms. And particularly the respiratory, for example, the opioid overdose is fatal because it depresses the respiratory system.
So you mentioned some cytochrome P450s like 3A4 and 2D6, which are responsible for metabolizing most of the drugs that we take. Can you describe some of the more common things that needed to be avoided if you're taking a drug that interacts with CYP3A4, like grapefruit juice or?
I know about the 2D6, in psychiatry, we use antidepressants. Mostly the 2D6 are the Prozac or the norfloxetine, and the sertraline are the 2D6. And then some of the other medications, they are the 3 or 4. But those are the few common antidepressants that we have to keep in mind.
So what are the most common concomitant health problems that you see in your patients that need to be managed while also dealing with their substance use disorder?
So most common problems that I see is obviously the post-traumatic stress disorder. We also see the TBIs. We also have patients, with bipolar or simple panic disorder. So we see like a full spectrum of disorders in the clinic, in the dorm.
Our last two questions are a little more general. What are some of the unique challenges and also rewards of a career in psychiatry?
So, I mean, psychiatry actually, I mean, every person has a different like feel or like for a specialty, but, to go into the psychiatry, I mean, a person obviously has to have like you have to like the field. Some of the things that you need to become a good psychiatrist. I feel like, you have to be a good listener. You have to pay attention to the little details. And the other thing is also like, you have to be more like, you have to have like empathy, or like, how to empathize with the patient. So those are the things for me in particular, I would say that when I came to America, I will be like brutally honest. I'm talking about 27 years ago, being an IMG. We have we were like exposed to psychiatry, or peds were open. But I did like a few months observership with a psychiatrist, and I just fell in love with the psychiatry. I love the neurobiology part of and how different neurochemicals work in the brain, and how different antidepressants, can work. So that was something which clicked with me, and I like that, and how we can work. We can help the patient as a whole by working on the biopsychosocial aspects of a patient. So that's what attracted me in psychiatry, that we just not deal with just like the disease itself, but we can help the patient as a whole. And that concept, like as biopsychosocial model, it's like a concept like which we use with the whole healthcare, which is like becoming very common or popular. But in psychiatry, we use this concept, all the time. For me, that's like the main thing, which attracts me in psychiatry. And obviously, the challenges are just like with any other field. Number one is the compliance of the patient, and number two is the awareness to get help. And because that if the person, does not want to take a medication, then or does not understand or realize, or does not has an insight about his mental issues or disorder, then it becomes very difficult.
No, I think it's been great in the last few years to see the shift towards, like, I feel like people who have been suffering with substance use disorder almost get depersonified, and people don't have the sympathy for them. Like, they don't realize that it is a disease. So recently you've seen the shift even in the terminology that's used to try and like increase the awareness and make people like realize that this is actual disease, and like put the emphasis back on these people.
True. Yeah, that's true.
So our very last question, I think people want to know what a day in your career is typically like, and then how do you manage your work-life balance as a psychiatrist?
So that's a very good question. My typical day is like, at the dorm is just like a typical day of a psychiatrist. But what's unique about this domiciliary is that it's an inpatient. So I have the flavor of both. I have worked in the outpatient for about 12 years as an outpatient psychiatrist. And then now this is like an inpatient, but it's a residential. rehabilitation inpatient. So it's not like an acute psychiatric inpatient, but it's a residential. So it has the flavor of actually both. Both outpatient and inpatient has pros and cons, but what I used to enjoy in outpatient was that the continuity of care, that you get to know the patient. And what I said in the beginning, for me, that why I love to be a psychiatrist is that I look at the patient as a whole. So when working at this domiciliary or the inpatient, patients are there for about 3 months or minimum 90 days, or they can be there for 6 months or sometimes for a year. So you are working with the patient on their mental health, mental disorder. You're treating them as a psychiatrist, you're working on the other aspects of the social life. For example, you're working on CWT, which is the compensated work therapy. You help them with the vocational therapy to get them back into their jobs, into their education, into their schools. You help them with their housing. Many of them are homeless, so you work with that. They have legal problems. You help them with the legal problems. Then we have the primary care in the dorm, so we help them with take care of their medical issues. So typically, being a medical director, my main job is to look into the, to get the consults, referrals. So my source of referrals and consults is from the different VAs, like the Dallas. I have patients who come from the inpatient floors. I get the consults. So most of my work is to review the patients and see if they are eligible, if they can come to the dorm directly from the hospital, because I want to avoid the relapse. If they go back, maybe they're in the hospital, they're going through the detox, and we can get them directly, from the inpatient. So these, and then some of these patients, they are outside in the community, so they call and we do like the referral. So we review them, and one of the major we have the major criteria for accepting them is if they are homeless, we accept them, or if they have some barriers to the outpatient care. For example, they don't have transportation, or they have used the intensive outpatient services but they are not successful, then we bring them in the residential. So that's what, that's the typical, day. And the balance, the other question was the life and the work balance. And I think it's a constant, it's a constant, struggle, and it's a constant effort, and you have to be conscious about it to make like a life work balance. Because and you just have to be aware of if there is imbalance somewhere. But but for me for me personally, I feel like that there are some of the things that we have to do anyways, to take care of ourselves. Those are the core things which we have to do. For example, like take care of your diet and eat good and health, exercise, eat good, sleep good, do some hobbies, like, if you enjoy. But these are the core things, which you have to do. But even when you are doing these core things, doesn't mean that you will have like a perfect balance of life and work. That comes from the awareness, and that comes from knowing, that you have to balance the life and work. For example, like, you can be doing everything which I said, the core things, but the life, can still be like, in a different, you're not manageable, or work, you may have issues, and then you have to consciously be aware of those issues and balance those. If you ignore those things, you cannot balance. For example, I mean, I'm asked like by so many, like how to balance work. But the thing is that, I mean, if you have to work, I mean, there are days when there are stressful work days, but then you have to see that if that stress is constant or happens day and night, then it becomes a problem. And how this is affecting your life, then you have to make a balance of that. But again, you have to first realize it and then balance it.
When I first started my PhD, they showed us a cartoon that said you have work, fun, and sleep. Choose two.
Yeah, and then again, I mean, for me, the life and work balance changes from time to time. For example, like, when I was like a medical student in your position, I mean, the life, I mean, you have to do the core things which we talked about. The life was just like studying all the time. I mean, passing the exam and all that. That was all about it, like work and life. But then, like, when you are in residency and when you start like a family, and it's a life is not just you. You have to balance your life with your family also. Like, then it becomes a little bit more complicated. You have kids, or spouse, that's what life is. Life is not just like you. Life is like with your family, that you have to make sure that you're spending time or giving time to your family, and then balancing that with work. That's a balance. And then after, like right now for me, like I mean, life is like I'm with my kids, with my family, my parents. So if I'm not doing the right things in my life, then that's an imbalance. And I have to consciously make sure that I'm taking care of the life, which is just not me. It's like everyone around me too. So, and then same with work. I mean, some days, you may have like stressful days. You work like 10 or 9 in the evening, but then you have to consciously make an effort to balance your work.
Well, that's all the questions that we have. Thank you so much for taking the time to talk to us today. The program that you work in sounds incredible. Like you're really making a lasting, significant impact on patients' lives.
I just love it. Yeah. Thank you so much.
All right, thank you so much, Dr. Hayee. Now we're going to conduct our closing session with our quiz and future session dates. So the link to the quiz for the session is now live. And again, you'll need a 70% or higher to pass and receive certification. That link should be sent in the chat. And now on to our next session dates. These dates will also be posted throughout our social media outlets, so be sure to follow us at TeleShadowing. And I'm looking forward to seeing you all next Saturday, November 26th at 10 a.m. Eastern Standard Time with another physician mentoring us in psychiatry. Thank you so much, everyone, for attending today's session, and we hope to see you in upcoming sessions as well. This concludes this week's shadowing. Thank you.
Thank you.